Hello, welcome to this presentation by Fertility Connected. Thank you for clicking on this video. Today we'll be discussing the ectopic pregnancies and miscarriage, their diagnosis and initial management. So the publication that we're using as a guideline today is the National Institute for Health and Clinical Excellence. And first we'll be looking at support and information giving regarding these two issues. So first off, treat all women with early pregnancy complications with dignity and respect. Be aware that women will react to complications or the loss of a pregnancy in different ways. Provide all women with information and support in a sensitive manner, taking into account their individual circumstances and emotional response. Healthcare professionals providing care for women with early pregnancy complications in any setting should be aware that early pregnancy complications can cause significant distress for some women and their partners, if not most. Healthcare professionals providing care for these women should be given training in how to communicate sensitively and breaking bad news. When it comes to non-clinical staff, such as receptionists working in settings where early pregnancy care is provided, they should also be given training on how to communicate sensitively with women who experience early pregnancy complications, as they will also be interacting with the patients. You should be aware that throughout a woman's care, that you should be giving her and, with agreement, her partner specific evidence-based information in a variety of formats. This should include, as appropriate, when and how to seek help if existing symptoms worsen or new symptoms develop, including a 24-hour contact telephone number for any queries, as well as what to expect during the time she is waiting for an ultrasound scan. This also may include what to expect during the course of her care, including expected management, such as the potential length and extent of pain and/or bleeding and possible side effects. This information should be tailored to the care she receives. Also provide the patient with information about post-operative care for women undergoing surgery, as well as what to expect during the recovery period, for example, when it's possible to resume sexual activity and/or to try and conceive again, and what to do if she becomes pregnant again. This information should be tailored to the care she receives. Also, provide information about the likely impact of her treatment on future fertility, as well as where to access support and counselling services, including leaflets, web addresses, and helpline numbers for support organisations. So after an early pregnancy loss, offer the woman the option of a follow-up appointment with a healthcare professional of her choice. Next, let's look at the early pregnancy assessment service that should be in place and provided for patients that have experienced miscarriage or ectopic pregnancies. So regional services should be organised so that an early pregnancy assessment service is available 7 days a week for women with early pregnancy complications, where scanning can be carried out and decisions about management can be made. So these early pregnancy assessment services should be a dedicated service provided by healthcare professionals that are competent to diagnose and care for women with pain and/or bleeding in early pregnancy, as well as offer ultrasound and assessment of serum human chorionic gonadotrophin (HCG) levels. Early pregnancy assessment services should accept self-referrals from women who have had recurrent miscarriage or a previous ectopic pregnancy or a molar pregnancy. All other women with pain and/or bleeding should be assessed by a healthcare professional, such as a GP, accident and emergency doctor, midwife, or nurse, before referral to an early pregnancy assessment service. Ensure that a system is in place to enable women referred to their local early pregnancy assessment service to attend within 24 hours if the clinical situation warrants this. If the service is not available and the clinical symptoms warrant further assessment, refer women to the nearest accessible facility that offers specialist clinical assessment and ultrasound scanning, such as a gynecology ward or A&E service with access to specialist gynecology support. So there are specific symptoms and signs of ectopic pregnancy, and the initial assessment should look out for these specific signs. So refer women who are hemodynamically unstable or in whom there is significant concern about the degree of pain or bleeding directly to A&E. Also be aware that atypical presentation for ectopic pregnancy is common. And also be aware that ectopic pregnancy can present with a variety of symptoms, and even if a symptom is less common, it may still be significant. So these symptoms include the common symptoms, which are abdominal or pelvic pain, amenorrhea or missed period, vaginal bleeding with or without clots. And the other reported symptoms that may also be significant include breast tenderness, gastrointestinal symptoms, dizziness, fainting and syncope, shoulder tip pain, urinary symptoms, passage of tissue, or rectal pressure or pain on defecation. So you also have, under the common symptoms, pelvic tenderness, adnexal tenderness, and abdominal tenderness. And other less common symptoms may also be reported as cervical motion tenderness, rebound tenderness or peritoneal signs, pallor, abdominal distension, enlarged uterus, tachycardia, which is more than 100 beats per minute, or hypotension with less than 100/60, or shock or collapse, as well as orthostatic hypotension. So during the clinical assessment of women of reproductive age, be aware that they may be pregnant and think about offering a pregnancy test even when symptoms are non-specific, and that the symptoms and signs of ectopic pregnancy can resemble the common symptoms and signs of other conditions, for example, gastrointestinal conditions or urinary tract infections. All healthcare professionals involved in the care of women of reproductive age should have access to pregnancy tests. So you should refer immediately to an early pregnancy assessment service for further assessment of women with a positive pregnancy test and the following on examination, including pain and abdominal tenderness, or pelvic tenderness, or cervical motion tenderness. And also exclude the possibility of ectopic pregnancy even in the absence of risk factors, because about a third of women with an ectopic pregnancy will have no known risk factors. You should also refer to an early pregnancy assessment service for women with bleeding or other symptoms and signs of early pregnancy complications who have pain, or a pregnancy of 6 weeks gestation or more, or a pregnancy of uncertain gestation, as the urgency of this referral depends on the clinical situation. So use expected management for women with a pregnancy of less than 6 weeks gestation who are bleeding but not in pain and who have no risk factors such as previous ectopic pregnancy, and advise these women to return if bleeding continues or pain develops, to repeat a urinary pregnancy test after 7 to 10 days and to return if it's positive. And a negative pregnancy test means that the pregnancy has miscarried. Refer women who return with worsening symptoms and signs that could suggest an ectopic pregnancy to an early pregnancy assessment service for further assessment. The decision about whether she should be seen immediately or within 24 hours will depend on the clinical situation of the patient. So if a woman is referred to an early pregnancy assessment service, explain the reasons for the referral and what she can expect when she arrives there. So now let's move on to the diagnosis of viable intrauterine pregnancy and of tubal ectopic pregnancies. So you should be aware that ultrasound is used for diagnosis. So offer women who attend an early pregnancy assessment service or out-of-hours gynecology service, if the early pregnancy assessment service isn't available, a transvaginal ultrasound scan to identify the location of the pregnancy and whether there is a fetal pulse and heartbeat. Consider a transabdominal ultrasound scan for women with enlarged uterus or other pelvic pathology such as fibroids or an ovarian cyst. So if a transvaginal ultrasound scan is unacceptable to the woman, offer a transabdominal ultrasound scan and explain the limitations of this method of scanning. Also, during the process, inform women that the diagnosis of a miscarriage using one ultrasound scan cannot be guaranteed to be 100% accurate, and there is a small chance that the diagnosis may be incorrect, particularly at very early gestational ages. And when performing an ultrasound scan to determine the viability of an intrauterine pregnancy, first look to identify a fetal heartbeat. If there is no visible heartbeat, but there is a visible fetal pole, measure the crown to rump length, and only measure the mean gestational sac diameter if the fetal pole is not visible. If the crown to rump length is less than 7 millimeters with a transvaginal ultrasound scan and there is no visible heartbeat, perform a second scan a minimum of 7 days after the first before making a diagnosis. Further scans may be needed before a diagnosis can be made. If the crown rump length is 7 millimeters or more with a transvaginal ultrasound scan and there is no visible heartbeat, you should seek a second opinion on the viability of the pregnancy and or perform a second scan a minimum of 7 days after the first before making a diagnosis. If there is no visible heartbeat when the crown rump length is measured using a transabdominal ultrasound scan, you should record the size of the crown rump length and perform a second scan a minimum of 14 days after the first before making a diagnosis. If the mean gestational sac diameter is less than 25 millimeters with a transvaginal ultrasound scan and there is no visible fetal pole, perform a second scan a minimum of 7 days after the first before making a diagnosis. Further scans may be needed before a diagnosis can be made. In the cases of the mean gestational sac diameter being 25 millimeters or more during a transvaginal ultrasound scan and there is no visible fetal pole, you should seek a second opinion on the viability of the pregnancy and or perform a second scan a minimum of 7 days after the first before making a diagnosis. In the case where there's no visible fetal pole and the mean gestational sac diameter is measured using a transabdominal ultrasound scan, record the size of the mean gestational sac diameter and perform a second scan a minimum of 14 days after the first before making a diagnosis. Do not use gestational age from the last menstrual period alone to determine whether a fetal heartbeat should be visible. Also inform women that the date of their last menstrual period may not give an accurate representation of gestational age because of variability in the menstrual cycle. Inform these women what to expect whilst waiting for a repeat scan and that waiting for a repeat scan has no detrimental effects on the outcome of the pregnancy. And give women a 24-hour contact telephone number so that they can speak to someone with experience of caring for women with early pregnancy complications who understand their needs and can advise on appropriate care. When diagnosing complete miscarriage on an ultrasound scan, in the absence of a previous scan confirming an intrauterine pregnancy, always be aware of the possibility of a pregnancy of unknown location. Advise these women to return for follow-up, for example HCG levels or ultrasound scans, until a definitive diagnosis is obtained. All ultrasound scans should be performed and reviewed by someone with training in and experience of diagnosing ectopic pregnancies. So when carrying out a transvaginal ultrasound scan in early pregnancy, look for these signs indicating a high probability of a tubal ectopic pregnancy, such as an adnexal mass moving separately to the ovary with an empty gestational sac. This is sometimes described as a tubal ring or a bagel sign, or a complex inhomogeneous adnexal mass moving separate to the ovary. Also, if these features are present, take into account of other intrauterine and adnexal features on the scan, the woman's clinical presentation, as well as serum HCG levels before making a diagnosis. You should also be looking out for an empty uterus or a collection of fluid within the uterine cavity, sometimes described as a pseudo-sac. So if these features are present, take into account other intrauterine and adnexal features on the scan, the woman's clinical presentation, and serum HCG levels before making a diagnosis, as mentioned previously. So when it comes to carrying out a transabdominal or transvaginal ultrasound scan in early pregnancy, look for a moderate to large amount of free fluid in the peritoneal cavity or the pouch of Douglas, which might represent a hemoperitoneum. If this is present, take into account other intrauterine and adnexal features on the scan, the woman's clinical presentation, and HCG levels before making a diagnosis again. And also, when carrying out a transabdominal or transvaginal ultrasound scan during an early pregnancy, scan the uterus and adnexae to see if there is a heterotopic pregnancy. All ultrasound scans should be performed or directly supervised and reviewed by appropriately qualified healthcare professionals with training in and expertise of diagnosing ectopic pregnancies. Be aware that women with a pregnancy of unknown location could have an ectopic pregnancy until the location is determined. Do not use serum HCG measurement to determine the location of the pregnancy. In a woman with a pregnancy of unknown location, place more importance on clinical symptoms than on serum HCG results, and review the woman's condition if any of her symptoms change, regardless of previous results and assessments. Use serum HCG measurements only for assessing trophoblastic proliferation to help to determine subsequent management. And also take 2 serum HCG measurements as near as possible to 48 hours apart, but no earlier, to determine subsequent management of a pregnancy of unknown location. And take further measurements only after a review by a senior healthcare professional. Regardless of serum HCG levels, give women with a pregnancy of unknown location written information about what to do if they experience any new or worsening symptoms, including details about how to access emergency care 24 hours a day. Advise women to return if there are any new symptoms or if existing symptoms worsen. For a woman with an increase in serum HCG concentration greater than 63% after 48 hours, you should be informing her that she is likely to have a developing intrauterine pregnancy, although the possibility of an ectopic pregnancy cannot be excluded in this case. Offer her a transvaginal ultrasound scan to determine the location of the pregnancy between 7 and 14 days later. Also consider an earlier scan for a woman with a serum HCG level greater than or equal to 1,500 international units per litre. If a viable intrauterine pregnancy is confirmed, offer her routine antenatal care, but in cases where a viable intrauterine pregnancy is not confirmed, refer her for an immediate clinical review by a senior gynecologist. For a woman with a decrease in serum HCG concentration greater than 50% after 48 hours, inform her that the pregnancy is unlikely to continue, but this is not confirmed, and provide her with oral and written information about where she can access support and counselling services, and also ask her to take a urine pregnancy test 14 days after the second serum HCG test, and explain that if the test is negative, no further action is necessary, whereas if the test is positive, she should return to the early pregnancy assessment service for clinical review within 24 hours. For a woman with a decrease in serum HCG levels less than 50% or an increase less than 63%, refer her for a clinical review in the early pregnancy assessment service within 24 hours. And for women with a pregnancy of unknown location, when using serial serum HCG measurements, do not use serum progesterone measurements as an adjunct to diagnose either viable intrauterine pregnancy or ectopic pregnancy. So preceding the early pregnancy assessment service, symptoms and signs and diagnosis, we'll move on to the management of miscarriage. So in cases of threatened miscarriage, advise a woman with vaginal bleeding and a confirmed intrauterine pregnancy with a fetal heartbeat that if her bleeding gets worse or persists beyond 14 days, she should return for further assessment, and if the bleeding stops, she should start or continue routine antenatal care. Use expectant management for 7 to 14 days as the first-line management strategy for a woman with a confirmed diagnosis of miscarriage. Explore management options other than expectant management if, in the case that the woman is at increased risk of hemorrhage, for example, she's in the late first trimester, or she has had previous adverse and/or traumatic experiences associated with pregnancy, for example, stillbirth, miscarriage, or antepartum hemorrhage, or if she's at an increased risk from the effects of hemorrhage, for example, if she's had coagulopathies or unable to have a blood transfusion, or if there's evidence of infection. You should offer medical management to women with a confirmed diagnosis of miscarriage if expectant management is not acceptable to the woman. and also explain what expectant management involves, and that most women will need no further treatment, also providing women with oral and written information about further treatment options. Be sure to give all women undergoing expectant management of miscarriage oral and written information about what to expect throughout the process, advice on pain relief, and where and when to get help in an emergency setting. If the resolution of bleeding and pain indicate that the miscarriage is completed during 7 to 14 days of expectant management, advise the woman to take a urine pregnancy test after 3 weeks and to return for the individualised care if it's positive. Continuing with expectant management, offer a repeat scan if after the period of expectant management the bleeding and pain have not started, suggesting that the process of miscarriage has not begun, or there are persisting and or increasing, so suggesting incomplete miscarriage in this case. Discuss all treatment options, continued expectant management, medical management and surgical management with the woman to allow her to make an informed choice about her care. Review the condition of a woman who opts for continued expectant management of miscarriage at a minimum of 14 days after the first follow-up appointment. And don't offer mifepristone as a treatment for missed or incomplete miscarriage. When it comes to medical management, offer vaginal misoprostol for the medical treatment of missed or incomplete miscarriage. Oral administration is acceptable as an alternative if this is the woman's preference. For a woman with a missed miscarriage, use a single dose of 800 micrograms of misoprostol. And advise the woman that if bleeding has not started 24 hours after the treatment, she should contact her healthcare professional to determine ongoing individualised care. And for a woman with an incomplete miscarriage, use a single dose of 600 micrograms of misoprostol. 800 micrograms can be used as an alternative to allow alignment of treatment protocols for both missed and incomplete miscarriages. Also, when it comes to medical management, offer all women receiving medical management of miscarriage pain relief and antiemetics as needed. Inform women undergoing medical management of miscarriage about what to expect throughout the process, including the length and the extent of bleeding and the potential side effects of treatment, including pain, diarrhea, and vomiting. Also advise these women to take a urine pregnancy test 3 weeks after medical management of miscarriage, unless they experience worsening of symptoms, in which case advise them to return to the healthcare professional responsible for providing their medical management. Also advise women with a positive urine pregnancy test after 3 weeks to return for a review by a healthcare professional to ensure that there is no molar or ectopic pregnancy. When it comes to surgical management, where clinically appropriate, offer women undergoing miscarriage a choice of manual vacuum aspiration under local anaesthetic in an outpatient or clinical setting, or surgical management in a theatre under general anaesthetic. Provide oral and written information to all women undergoing surgical management of miscarriage about the treatment options available and what to expect during and after the procedure. It's also important to inform women who have had an ectopic pregnancy that they can self-refer to an early pregnancy assessment service in future pregnancies if they have any early concerns. Also surrounding the topic of management, we'll now discuss the management of tubal ectopic pregnancy. So there are surgical and medical management options. So give all women with an ectopic pregnancy oral and written information about the treatment options and what to expect during and after treatment, how they can contact a healthcare professional for advice after treatment if needed, and who this will be, as well as where and when to get help in an emergency. Give all women with an ectopic pregnancy oral and written information about no significant pain, an unruptured ectopic pregnancy with an adnexal mass smaller than 35 millimeters with no visible heartbeat, also a serum HCG level less than 1,500 international units per litre, and also no intrauterine pregnancy as confirmed on an ultrasound scan. In this case, offer surgery where treatment with methotrexate is not acceptable to the woman. Offer expectant management as an option to women who are clinically stable and pain-free and have a tubal ectopic pregnancy measuring less than 35 millimeters with no visible heartbeat on transvaginal ultrasound scan, and have a serum HCG level of 1,000 international units per litre or less, and are able to return for a follow-up. And consider expectant management as an option for women who are clinically stable and pain-free, have a tubal ectopic pregnancy measuring less than 35 millimeters with no visible heartbeat on transvaginal ultrasound scan, and have a serum HCG levels above 1,000 international units per litre and below 1,500 international units per litre, and are able to return for follow-up. So for women with a tubal ectopic pregnancy being managed expectantly, repeat HCG levels on days 2, 4 and 7 after the original test, and in the cases where the HCG levels drop by 15% or more from the previous values on day 2, 4 and 7, then repeat weekly until a negative result is obtained, and this negative result is less than 20 international units per litre. If HCG levels do not fall by 15%, stay the same or rise from the previous value, review the woman's clinical condition and seek senior advice to help decide further management of the patient. Advise women that based on limited evidence, there seems to be no difference following expectant or medical management in the rate of ectopic pregnancies ending naturally, also in the risk of tubal rupture, as well as the need for additional treatment, but that they may need to be admitted urgently if their condition deteriorates, also in cases where the health status, depression or anxiety scores. Advise women that the time taken for ectopic pregnancies to resolve and future fertility outcomes are likely to be the same with either expectant or medical management. Offer surgery as a first-line treatment to women who are unable to return for follow-up after methotrexate treatment or who have had any of the following, including an ectopic pregnancy and significant pain, or an ectopic pregnancy with an adnexal mass of 35 millimeters or larger, or in cases of an ectopic pregnancy with a fetal heartbeat visible on an ultrasound scan, also during ectopic pregnancy with a serum HCG level of 5,000 international units per litre or more. Offer systemic methotrexate to women who have no significant pain and have an unruptured tubal ectopic pregnancy with an adnexal mass smaller than 35 millimeters with no visible heartbeat and have a serum HCG level of less than 1,500 IU per litre and do not have an intrauterine pregnancy as confirmed on an ultrasound scan, and last but not least are able to return for follow-up. So methotrexate should only be offered on a first visit when there is a definitive diagnosis of an ectopic pregnancy and a viable intrauterine pregnancy has been excluded. So offer surgery where treatment with methotrexate is not acceptable to the woman. When it comes to salpingectomy and salpingotomy, methotrexate should only be offered on a first visit when there is a definitive diagnosis of an ectopic pregnancy and a viable intrauterine pregnancy has been excluded. So offer surgery where treatment with methotrexate is not acceptable to the woman. Offer the choice of either methotrexate or surgical management to women with an ectopic pregnancy who have a serum HCG level of at least 1,500 IU per litre and less than 5,000 IU per litre, who are able to return for follow-up and who meet all of the following criteria, including no significant pain, an unruptured ectopic pregnancy with an adnexal mass smaller than 35 millimeters, with no visible heartbeat, and no intrauterine pregnancy, which is confirmed on an ultrasound scan. So advise women who choose methotrexate that their chance of needing further intervention is increased and they may need to be urgently admitted if their condition deteriorates. For women with ectopic pregnancy who have had methotrexate, take 2 serum HCG measurements in the first week, which are days 4 and 7, after treatment, and then 1 serum HCG measurement per week until a negative result is obtained. So if the HCG levels plateau or rise, reassess the woman's condition for further treatment. When surgical treatment is indicated for women with an ectopic pregnancy, it should be performed laparoscopically whenever possible, taking into account the condition of the woman and the complexity of the surgical procedure. Surgeons providing care to women with ectopic pregnancy should be competent to perform laparoscopic surgery. Offer a salpingectomy to women undergoing surgery for an ectopic pregnancy unless they have other risk factors for infertility. Consider salpingotomy as an alternative to salpingectomy for women with risk factors for infertility such as contralateral tube damage. Commissioners and managers should ensure that equipment for laparoscopic surgery is available, and inform women having a salpingotomy that up to 1 in 5 women may need further treatment. This treatment may include methotrexate and/or salpingectomy. For women who have had a salpingotomy, take 1 serum HCG measurement at 7 days after surgery, then 1 serum HCG measurement per week until a negative result is obtained. Advise women who have had a salpingectomy that they should take a urine pregnancy test after 3 weeks, and advise women to return for further assessment if this test is positive. So last but not least, we'll be looking at AntiRhesus Prophylaxis as the last chapter for this presentation. So offer AntiRhesus prophylaxis at a dose of 250 IU, which is 50 micrograms, to all rhesus-negative women who have had a surgical procedure to manage an ectopic pregnancy or a miscarriage. Do not offer AntiRhesus prophylaxis to women who receive solely medical management for an ectopic pregnancy or miscarriage, or have a threatened miscarriage, or have a complete miscarriage, or have a pregnancy of unknown location. And do not use a Kleyor test for quantifying fetal-maternal hemorrhage. So this is the end of the presentation. Thank you for listening and thank you for your time. This has been the presentation on ectopic pregnancies and miscarriages, and we hope that all of your questions have been answered.